discussing this journal about the radiologic diagnosis of patients with COVID-19 by Chamorro et al. Just a short introduction. The burden of COVID-19 affected 141 million cases with approximately 3 million deaths worldwide. While in the Philippines, we have recorded over 900,000 cases and over 16,000 deaths. So, what is the role of imaging? The standard test for diagnosis of COVID-19 is RT-PCR. So imaging tests play an important role in detection and management of these patients, have been used to help diagnose the disease, determine the severity, and guide and assess treatment response. Current recommendation of the vast majority of radiologic associations is that imaging tests should not be used as screening tools for detecting COVID-19. Rather, they should be reserved for evaluating complications. So the study of clinical, laboratory, and imaging factors associated with disease severity is key to promoting effective treatment strategies that reduce complications and mortality. So first, I will be discussing the chest X-ray. So the chest X-ray is the initial imaging of choice since it is widely available. However, using chest X-ray has its limitations. It can yield false positive results, which may be due to the use of a portable X-ray, lack of inspiration, the breast prominence or the soft tissue prominence, poor positioning, which can lead to the scapulae and soft tissue projecting onto the lung fields, thus increasing the density of the lung periphery and simulating ground glass opacities. Another factor is the time of imaging. If there is prematurity of imaging, it may present with a normal chest X-ray. But as we know, the absence of pulmonary findings in the chest X-ray at the time of presentation does not exclude the disease. So these are examples of false positive or pitfalls in chest X-ray. This is a PE view of a chest X-ray with poor inspiration in a case of a 38-year-old woman who presented with signs and symptoms of COVID-19. As we can see, there are bilateral increase in density, predominantly in the middle and lower fields, raising suspicion for COVID pneumonia, as shown by the arrow tips. While image B is the same patient with a repeat chest X-ray a few minutes after forced inspiration, wherein all above mentioned findings are no longer seen. You can also note that there is a change in the morphology of the cardiac silhouette. So here is another example of a false positive chest X-ray showing bilateral symmetrical opacities in the lower lung fields as pointed by the arrows due to highly dense breast tissue. But this patient also presented with a negative PCR result. So they categorized X-ray findings into four as follows. So the first is a typical X-ray findings, which usually shows a reticular pattern with ground glass opacities, consolidations with rounded morphology, and a confluent or patchy multifocal distribution. It is usually bilateral with peripheral and lower lung dominance. For the differential diagnosis of typical X-ray findings are organizing pneumonia, drug toxicity, and other causes of acute lung damage. So this is an example of typical X-ray findings for COVID pneumonia. Image A shows reticular interstitial pattern, as pointed by the arrows, with peripheral predominance. Then image B shows the same patient 3 days later. Despite being taken with poor inspiration, the X-ray shows faint, rounded, bilateral peripheral alveolar opacities pointed by the dotted arrows. So here are additional typical findings of HS X-ray. Image C is a 57-year-old male with dyspnea and positive PCR that shows bilateral peripheral opacities in upper, middle, and lower fields as pointed by the arrow tips. While image D is a 45-year-old male with dyspnea showing multiple bilateral diffuse confluent areas of consolidation with extensive involvement of both lungs. There is a note the presence of two central lines, venous lines, and a feeding tube. So for the typical findings, the proposed diagnosis by an article by Litmanovich et al. Findings consistent with COVID-19 pneumonia outside of an appropriate epidemic context. These findings may overlap with those of other respiratory infections, drug reactions, or other causes of lung damage. So next are the indeterminate findings. These are findings that may be present in cases of COVID-19 pneumonia, but can also have other causes. These include consolidations and ground glass opacities, but has a unilateral distribution, central or upper lobe involvement. So differential diagnosis for indeterminate findings are other infections or alveolar edema. So this is an example of an indeterminate finding because it has a unilateral and has upper lobe involvement. So the proposed diagnosis for indeterminate findings is findings indeterminate for COVID-19 pneumonia. Outside of an appropriate epidemic context, they may or may not be associated with other causes of infectious origin. So next are the atypical findings. These are uncommon findings or findings not usually reported in COVID-19 pneumonia. These include lobar consolidation, lung nodules or masses, a miliary pattern, cavitation, or pleural effusion. So the image B and C is a PA and lateral chest radiograph of a 17-year-old male with fever and is COVID positive. The PA view shows faint bilateral infiltrates in the lower fields as pointed by the arrows, and the lateral view shows minimal pleural effusion in the left posterior costodiaphragmatic sinus as shown by the arrow tip. So for the proposed diagnosis, findings atypical for COVID-19 pneumonia, consider alternative diagnosis. This is just a summary of what I have discussed. This is a classification of COVID-19 findings on chest X-ray. And this is based on an article by Litvanovich et al. So, multiple publications established criteria to grade the severity of the involvement seen on chest X-rays in patients with COVID-19. And their objectives are to establish a common language to classify disease severity in these patients, to correlate severity of radiological involvement with clinical and demographic parameters, to aid in monitoring with clinical progression. But as of the moment, international organizations have not recommended using any of these existing systems systematically. But I will just be briefly discussing them. So this is the study method, grading method suggested by Borghesi et al. They use an upper horizontal line at the lower edge of the aortic arc and a lower horizontal line at the lower edge of the right inferior pulmonary vein with 6 lung fields. So 6 lung fields are obtained. And each field is assigned a score based on the radiological findings. So the maximum score for this is 18. So this is a study by Warren. This is the proposed method by Warren et al. Initially devised to grade the severity of acute pulmonary edema using a vertical line along the spine and a horizontal line along the lower edge of the left main bronchus. So 4 quadrants are obtained. And each quadrant is assigned a score of 0 to 4 depending on the extent of the consolidation or ground glass opacities, and it is multiplied by the consolidation density. So the maximum score for this is 48. So the next grading method is used by Schalekamp et al. This divides the thorax into 4 quadrants. Each quadrant is assigned a score of 0 to 2 with a maximum score of 8. And in this study, they found that scores averaging from 4.4 to plus minus 0.9 and bilateral involvement were associated with critical illness. So Next, I will be discussing the chest CT computed tomography findings. So high resolution chest CT is a quick, accessible test considered to be the most sensitive imaging test for detecting COVID-19, with a reported sensitivity of up to 97%. Some studies have found that chest CT's findings may precede positive RT-PCR results. So chest CT scan is useful for guiding management in complex cases, in patients with clinical worsening, and for ruling out alternative diagnosis. It is also one of the main imaging tools for assessing infection severity, and it enables stratification of patients into risk categories and estimation of their prognosis, therefore aids in clinical decision making. It is also used when microbiological diagnosis is not possible. So these are the typical X-ray findings, and I will be discussing them briefly one by one. Ground glass opacities consist of a slight increase in lung attenuation such that the lungs are transparent without obscuring underlying vascular structures. It is the predominant finding regardless of disease stage, and it is the earliest finding that we can see. So this is a HLCT chest CT with ground glass opacities as pointed by the arrow, with rounded morphology and a peripheral and subpleural distribution. So next is consolidation. It consists of an increase in lung attenuation that obscures vessels and airway walls. Consolidations represent the second most common pattern and appear in association with ground glass opacities, or less frequently alone. So they are indicative of disease progression. So this image shows consolidations with peripheral and subpleural predominance. Peripheral articulation, this is due to the thickening of the interlobular and intralobular septa, and this increases with prolonged disease course. So the arrow tips shows reticulation with the peripheral and subpleural location. So next is a crazy paving pattern. Are linear patterns due to thickening of interlobular septa overlapping with an underlying ground glass pattern. It is due to alveolar edema and acute interstitial inflammation. And this is another sign of disease progression. So this image shows peripheral ground glass opacities with overlapping interlobular septal thickening in relation to the crazy paving pattern as shown by the arrow. There is also peripheral consolidation as noted by the asterisk. So other less common findings are they are uncommon findings but are still considered to be among the typical findings. So the reverse halo sign represents a central ground glass opacity surrounded by a crescent or a ring-shaped consolidation. It is unclear whether it reflects consolidation improvement or ground glass progression. Though this is not usually a common finding, but it is considered to be one of the typical findings. So image A is an axial and image B is a sagittal view showing a lesion in the posterior segment of the right upper lobe with reversed halo signs as pointed by the arrows. So the air bubble sign refers to a small hypodense pulmonary space less than 5 millimeters within the ground glass opacity. It could correspond to a pathologic dilatation of a normal space or a cross-section of bronchiectasis, or it could be secondary to the resolution of consolidations. So you can see in the image C, it shows extensive ground glass involvement with areas of consolidation in the right lower lobe with vacuolar signs as shown by the arrow tips. So airway changes with bronchial dilations showing abnormal architecture in the architecture of the right lower lobe with a crazy paving pattern and bronchial dilation. Image Z shows ground glass areas and bronchial wall thickening because of the inflammation. So prominent vessels are due to the dilatation of perilesional or interlesional pulmonary vessels due to the capillary wall damage in response to inflammatory factors. So the arrow points to a vascular thickening with associated area of ground glass opacity as pointed by the asterisk. So Next are pleural and subpleural abnormalities. The first is the subpleural curvilinear line, which is a thin curvilinear opacity with a thickness of 1 to 3 millimeters parallel to the pleura and less than 1 centimeter from the pleural surface. It is related to edema or fibrosis. So next is the subpleural parenchymal band, which are linear opacities, usually 1 to 3 millimeters thick and up to 5 centimeters long. And it is perpendicular and usually extending to the visceral pleura as pointed by the arrows. It is often thickened and retracted at the point of contact with the visceral pleura, as, and it reflects parenchymal fibrosis and usually associated with distorted lung architecture. And last, for the typical findings, is a hypoattenuating line that is seen between the visceral pleura and the ground glass opacities, as pointed by the arrow tips. So next are the indeterminate findings, which are non-specific forms and presentation since they may be seen both in COVID pneumonia and pneumonia caused by other pathogens, and even in non-infectious diseases. So these are non-peripheral patchy ground glass consolidations or opacities with a unilateral distribution more common in the upper lobes. Ground glass fibrosis, lymphadenopathy, and pleural effusion. So for the atypical findings, which consists of cavitation, calcification, well-defined solid nodules or masses, bronchiolitis tree-in-bud pattern, focal consolidation, diffuse ground glass opacities with peribronchovascular distribution, and fibrotic changes. If these are the findings, these may point to an alternative diagnosis. So negative CT results should not be used to rule out the possibility of COVID-19, particularly in the early stages. So there is a link between radiological findings and time elapsed since the onset of symptoms. Four stages have been reported according to the evolutionary stage of infection. So in the early phase, ground glass pattern is usually seen, but CT scans can also be normal. Therefore, a normal study does not rule out the disease. So for the next 5 to 8 days, or the progression phase, there is usually ground glass opacities which progresses rapidly in extent and becomes bilateral and diffuse with multilobar involvement. In this stage, areas of crazy paving pattern and consolidations may appear. So for the peak phase is where the maximum involvement is seen, where previously seen ground glass opacities turn into consolidation. And in this stage, bronchograms, crazy paving pattern, and reverse halo sign may be seen. So for the last phase, which is the resolution phase, it is a resorption of consolidations, and ground glass opacities are again seen that may be associated with bronchial dilations with subpleural distortions. So this is an example of progression of COVID-19 pneumonia in a 56-year-old woman. So this first image is a HL CT scan 10 days after the onset of symptoms. As you can see, there are peripheral bilateral ground glass opacities as pointed by the arrow tips, this one, and a small consolidation forming at the posterior segment of the right upper lobe. So this is a CT scan 15 days after the first scan, which shows conversion of the previously seen ground glass opacities to consolidation, as pointed by the arrows. So this last CT scan is 32 days after the first CT scan that shows partial resorption of the consolidations that pointed by the arrow tips and focal pleural thickening in the apical posterior segment of the left upper lobe, pointed by the black arrow. So a structured report offers a standardized language that can be understood by the entire medical community. It must be correlated with clinical suspicion, duration of symptoms, and local prevalence. So the RSNA proposed 4 categories, and it is similar to the categories that I discussed previously for the proposed report for chest x-rays. While the Dutch Association of Radiology developed the CORADS classification with a 5-point scale for suspicion from very low to very high. So, medyo wordy po. This is a classification findings for COVID pneumonia based on the RSNA. So, um, with the corresponding suggested reporting language depending on the appearance. And this is a Kural's classification of the COVID working group of the Dutch Radiological Society. Proposed standardized CT reporting systems for patients with suspected COVID-19 in a setting of moderate to high prevalence. So in the CURADs, the higher the score, it means the higher the possibility or suspicion for COVID. So it is also nice to know that there are multiple semi-quantitative scales which have been proposed for CT scans that can visually calculate the extent of the abnormalities. But it is not widely used because they have a disadvantage in their lack of precision. So in conclusion, imaging tests play an important role in detection, management, monitoring, and grading the severity of COVID patients. Initial imaging includes a chest X-ray, which may be normal in the early stages, and chest CT scan is usually used to detect possible complications and alternative diagnosis, or when microbiological diagnosis is not possible. So the typical findings of COVID pneumonia is characterized by ground glass opacities, which are bilateral, peripherally dominant, and common in the lower lung fields. So these are my references po, and thank you.
Thank you so much, Izel. Izel, very helpful yan, no? Could you go back to the table, yung table for the X-ray?
Okay.
Because sa nababasa ko sa chest CT, maganda interpretation natin. We're really guiding the clinician na, oh, this is COVID, this is typical for COVID. But for X-ray, medyo nagkakaiba-iba tayo. So, para man lang dyan, unified tayo, Dr. Arches, Dr. Mike Corsino, ako, Doc Jet. Hindi lang isa ang gumagamit ng proposed diagnosis. I asked you to report on this, which fortunately, naging 2-in-1. Because not just a review for our institute, for our residents, for you, but also as a review for the in-service. Kasi eksakto, ang ibinigay na journals, all about COVID and the grading, the criteria, the reading. So, I think you've covered the 5 journals na, the content of the 5 journals with this one report. So, nabawasan ang trabaho natin. Thank you sa iyo, Izel. I would ask all of you guys here, especially our first years, anong observation ninyo? Hindi natin ginagamit ito. Would it be very helpful? Do you have any negative comments about this? Would this make our lives worse, or would this make our lives easier? What do you think, guys, before we implement this?
It might be easier than Doc kasi at least may parang flow na susundan po.
Yes. Kakausapin ko si Chester, and does everyone agree? Kasi first years and second years, kayo ang nagtutulungan sa X-ray eh. Would it be all right that we would make a separate template? That would be easier for you. Magkakaroon tayo ng separate template for this. And not the findings but yung mismong diagnosis na. Kasi this will really guide our clinicians. So okay ba tayo lahat doon?
Yes po, Doc.
Oo, salamat sa inyo ha. So, yun ang aim natin for this morning. Bakit natin pinareport ito? And as a review for you guys. And then hopefully by next week, mag-agree naman lahat ang X-ray consultants on this. Na pag nag-release tayo ng report, kahit hindi nakalagay doon sa complaint na rule out COVID, basta nakalagay doon, rule out infection, cough, we would give them this proposed diagnosis. Kasi, syempre, always at the back of our minds is pandemic time. Lahat ng opacity na yan. COVID ba yan? COVID ba yan? Ganun naman ang question eh. So, let's help each other, especially our ER consultants. Pagka ganito ang reporting natin, I think mas directed yung action nila. Pagka ganun. Kaysa ilalagay natin pneumonia versus atelectasis. Papakamot na lang ng ulo yung mga yun eh, pagka ganun. No? So if we give them this kind of report, it shows that you have confidence, it shows that you know what you're doing, and yun naman talaga gusto nating i-build up sa inyong lahat. No? Okay, guys? Ezel, Kevin, JV, and Chester. I know you're doing all well. Galingan pa natin, ha? Okay?
Yes po, Doc. Thank you po.
Oo. Salamat sa inyo. Chester, I will communicate with you within the day, ha? Thank you so much.
Thank you po, Doc.
Oo, salamat. Oo,
Thank you po, Doc.
salamat. Oh, maiwan naman sina Benjo. Lilbert, I'm thankful that you are here. Mabuti naman. Ezel, thank you so much. Very big help.
Welcome po.